I want to speak how neuroscience help us to treat orofacial disorders. And as Mark said, it is the foundation of orofacial myofunctional therapy. The learning objective is to introduce the different ways to improve swallowing, to discover a new approach to restore nasal breathing and myofunctional balance, to understand the associated unconscious physiological and biochemical change in the brain when we do this myofunctional therapy, and then to be able to use this method in your patient. The basic concept is very simple. People have an unconscious ability to coordinate a movement to make it meaningful and effective. The coordination is controlled by a set of neurons connected at synapse, where alternating electrical and biochemical processes from the originated neuron through intermediate neuron that can be from 4 to millions to the destination one. And the system would be a vast network of neurons grouped together by a mechanism of inhibition and activation. The functional balance is not a stable state we must reach, but it's a state in a perpetual reorganization. And the information are constantly analyzed and general ignored very quickly, but it can lead to an unconscious and anoetic reorganization if it is relevant. Anoetic memory is expressed without consciousness directly in action. That was a definition from Tulling. And the reinforcement of existing neuronal circuit or the integration of new information make it possible to ensure proper orofacial functioning. So when nature does well the thing, what happened? The development of sucking swallowing, the brain stem controls the development of sucking swallowing in utero, and these abilities are present at birth. During the gestation, the fetus is in an aquatic environment at a constant temperature and with continuous feeding. These brain cells control the development of the sucking swallowing in utero. And these abilities are present at death. And fortunately, because during the gestation, the fetus was continuous feeding. And after the physical challenge of a birth, the baby must breathe for the first time. The neonatal is more not continuous feeding. And fortunately, he has been trained to challenge his stress. Around the 11th week, the first swallows appear. And from this period, each swallowing in the amniotic fluid will allow the fetus to enrich its motor and sensory experience and improve its functional and cognitive skills. This will allow the development of a body diagram of the oral face and will lead to the first physiological function of a human at the 15 weeks, sucking, swallowing. And the fetus will swallowing and regurgitated more than 50% of the total amniotic volume per day, which is a quantity equal to the volume of milk it will drink at birth. So at birth, the control motor skills of the newborn is carried out at the level of brainstem. And we are very surprised when we see the newborn by the contrast between the overall incoordination of the movement and the perfect harmony that govern the mobility of the lips, the tongue, the pharynx, when sucking and swallowing. And the neurophysiological control of the motor activity of the tongue is synchronized with the respiratory, the cardiac, and digestive function. The sucking program controls the swallowing by a reflex action. And so what happens when the baby swallows? The mandible is stabilized by the contraction of the facial muscle. This notion of stabilization of the mandible is very important, we can see later. The saliva is swallowed by the pressure difference between the anterior mouth and the posterior mouth. And as soon as the nickel of the bottles come into contact with the mouth, the newborn takes the lips and produces an intrabuccal vacuum with back and forth movement of the tongue that acts as a suction pump and trigger the pharyngeal phases. Ideally, the tongue will create suction with the nipple against the palate. The tongue completely fills the buccal cavity and establishes contact between the lateral part and the cheeks, and between the anterior part and the labial muscle. But it requires a seal at the lips, which is caused by the contraction of the lips, and this contraction is controlled by the facial nerves. What happens so when the diet changes? Change in the diet will progressively introduce a cortical activity in the deglutition program's control. The secondary orality implies the start of maturation of the motor and gnosic, parietal, and frontal cortical area in the brain. The innate behavior are partially replaced by programs that take experience and learning into account. But they coexist with a primary feeding for a certain amount of time. And initially it was a reflex, and then the behavior become unconscious, automatic. The neurological commands and the neurological control centers for swallowing and sucking are different. And up to about the age of 4, this pattern is called primary swallowing. About the age of 4, a new mechanism of swallowing naturally takes place for 60% of children, the secondary swallowing. The mechanism is quite different. When there is apparition of the mastication, there is a nerve growth factor increases in the salivary glands that promoting the neurogenesis and the formation of new synapses. There is epidermal growth factor who increase also in the parotid and in the submaxillary gland. And there is the brain-derived neurologic factors who also increase is the hippocampus. And it's the most important moment for changing the problem and leaving babies' function to which will be the adult function. And that when that takes place, the new functional balance will favor the amorphic growth of the maxilla thanks to the trijumeau. So what is the influences of this change of swallowing? And when I say the change of swallowing is also to change the posture, because you can't change the function if you don't change the posture. And by the muscular forces that it generates, it will promote an optimal growth of the jaw, and all this with having no exercise. It will be all naturally modification. And that's why we can find 50% of the children will have a functional and an aesthetic occlusion without the need of orthodontic treatment. The orthodontic, of course, so only children we have problem, but pediatric dentists, pediatrics, they know that 50% of children will never need an orthodontic treatment. And if the primary swallowing remains, this function that was a physiological function at the beginning, but it will become dysfunctional and it will lead to dysmorphosis. We can see lots of kind. We can find for 3 years, 2 years, 3 years children, open bat, narrow maxilla, which will have consequences of breathing and nasal breathing, prognathy, lack of place for all the, and while there is not enough place for the teeth, you never see not enough place for the brain in the cranial. Very few, there is no problem of disharmony between the eyes and the orbital. There is a cooperation of the growing, control each other, that will be harmonious. And for teeth, some teeth, there is no place. Why there is no place? Because the maxillary is not enough developed. When this modification appeared, it was by a bottom-up action, modification. And it's very important because this modification are obtained through an anoetic approach. Anoetic approach means that it's not the brain we control the movement, it was a lower brain, and we activated the sensitive area, the motor area, naturally, and the child don't take care. He says, oh no, I am 4, no, I must change my swallowing program. No, oats appear naturally. And the new sensory information will go up to the sensory motor area through the bottom-up pathways. And it will constitute a new neural circuit. And Eric Kandel was very important to understand what happened, because when this appears, there is a new connection, new synapse, and a new network. This potential for changing the behavior comes from the brain and is controlled by genetic. But genetic is not 100% of a change. And however, endogenous or innate factors only produce option, possibility. And we must know, it was a work from Pimandinis in Boston, that neurons are not enslaved by its genes. And it's very important because for orthodontics, sometimes there is grace dysmorphosis and the parents go to orthodontists and they say, oh, it's genetic, I can't do anything, we will have a surgical treatment. Sometimes they try, but without good results. oh, it's not my fault, it's genetic. No, all genetic is not responsibility of us. Oh. And the genes will not be expressive unless the adequate exogenous condition arise and arise at the right time. There is a good window for the changing, and if you lose this window, it will be much more difficult to obtain naturally these modifications. And Dawson Church says more genes are activated or deactivated by our belief, our emotion, our attitude. It's very important to understand what are the good environment for the good development of the children. And to explain this difference between genetic and epigenetic, I take this example. The genetic is the partition of a fifth symphony of Beethoven. But if you give this genetic information to 5 different orchestra, you will not have the same music. That is epigenetics. And which is very important, it's that epigenesis is a molecular mechanism that make it possibility to irritably change of expression of them without altering ADN sequences. And there are 3 main causes of continuated sucking swallowing. And the first one is the child never had the opportunity to discover a new mode of functioning. Why? Because they continue to the bottle, there is a small, low feeding, no stimulation, and says, oh, yes, I try this, but it's not very useful for me. I can use my old program. And it's very nice for me to continue with a bottle, with a pacifier, and I don't want to change. And the mother also very often responsibility, because when the mother prepares the bottle, what she says, oh, stay my baby, stay my baby. So there is an organization and complicity between the child and the mother. And the last reason, or one of the last reasons, is that the anatomical environment is already too deformed to allow the implementation of a new program. And Professor Cooley says that the maintenance of a sucking maintain a certain delay in the setting of a mastications praxis. And that cases, they are not old, but the dysfunction has leads such dysmorphosis that it is impossible to change naturally. How you can, you want the tongue go upper against the palate when there is a so narrow palate, when there is a so open bite. And even class 3, when there are stimulation, there are not genetics, but there are bad posture of the tongue, grow, the upper maxilla doesn't grow, and there is very big class 3. And a lot of orthodontists, when they say this, say, oh, it's impossible with orthodontic treatment. We must have GRG A2. And it's the same thing for class 2. When you have 18 millimeters of difference between the upper and lower, sometimes we can see that there is surgical for 5 millimeters. When you have 18, lots of children, practitioners says it will be impossible with my mechanics to earn that. And it's possible. But in all this dysfunction, there are a constant for each patient. It's the need of a seal at the level of the lips, which is obtained by the activity of the facial nerves. When you are in sucking deglutition, always you need this seal, and you can see the activation of the lower lip controlled by the facial nerves. And these cases are good indication to start early orthodontic treatment. And we must know that early orthodontic treatment is not only an occlusal treatment, is a global development. And this girl, she has problem at school, and we begin a treatment. It's better, and immediately she change, and she will become happy. And we have treated the scholar problem, and not totally the dental problem, but we can directly help the children, treating them very early. This girl also, when she go to school, every friend says, "Oh, you are a pig, you are." And we treated in 1 year, and we changed completely the face of this girl in 1 year with a small appliance. And you can help these children to have an happy young and happy relationships with their friends. The big open bite I treat, he has 2 phases of treatments with re-education, but before the first definitive teeth grow, the occlusion is good. And if the occlusion is good at 5, the teeth will go in the correct place and don't need any complementary treatment. But for the 40% of the subjects who have not changed their function, what can we do? And there is some reason we have seen that is epigenetic, but frequently the maintenance of a mouth breathing is very important in this change. And nasal breathing is that the breathing for the newborn naturally. And during the rhinopharyngeal problems, sometimes a metacircuit was created, initially temporarily, but which have become automated and replace or complete the physiological breathing. And so we can see children at 3, at 4, with a mouth breathing, completely untreated by the doctor, the pediatricians. And there is many practitioners who make the respiratory rehabilitation as a priority. And we will come back to this, because in the States there are more than in Europe. Phase breathing is the most important. But it's impossible to treat only breathing without treating all the function. And on the beginning, the stomodeus is the mouth and the nasal breathing. And punctually, when the child puts this head back, there is upper maxillary, 2 upper maxillary, who will separate it, but it's the same neurological beginning. And you can see very often some children, we can see very easily that air can go through the nose. And it's emphasized, and we must also treat the nasal breathing. So what to do? And I don't know this Dr. Fuller, but I think it's very interesting what he says. You never change things by fighting against reality. If you want to change something, build a new model that makes the existing model obsolete. And what brings us the neuroscience? Because when we are in this solution, what is the possibility? There is a lot of orthodontics who says, oh, I don't care about function, and maybe there is dysfunction because there is occlusal dysfunction, and when I will have treated my arches, everything will become correct. Of course, sometimes it happened, but it will happen more if you take care about that, if you don't take care. And Pimandeli, so there is a possibility, so I don't take care, and we will see. There are also the trainers, and the trainers are very used. They have been imagined by Farrell in Australia. I think Farrell is here, no? And Bergensen. And they are frequently prescribed, but for the young children it's very difficult to put an appliance 2 hours a day and to sleep with shorts. And when you do the practice, you know that they don't wear it all night. It's important because the quality of the sleep is very important to consolidate what is learning at school. And anyway, we can't learn during night. During night, there is the encoding that as what has been learned during the church. There is sleeps promotes the consolidation of the memory traces, particularly when learning motor sequences. That's what we want first to treat. We are not the school, but we want to modify a function. And you can't learn modification of a function during night. The A, which is a famous neurophysiologist, sleep facilitated the automatization, but the sleeping brain learns practically nothing during the night. So the third one is to use the rehabilitation specialists. And the orofacial myofunctional therapist will set up a strategy by a cortical way to enable this imprinting. First, the patient becomes aware of a gesture that he usually carries out. And then the gesture that he must carry out until repetitions enable this action to become automatic. We are in a top-down approach, not bottom-up, but top-down, and the orders start from the cortical part to descend toward the motor effectors. And what is the efficiency? You know, the most experienced myofunctional therapists themselves admit that it's a long and it's a difficult wait. And it's not enough to know what you have to do to be able to do. If you learn golf or skiing, the teacher say, oh, you must do that, but it's not that you know what you must do, that you can do easily, automatically, and so. And we can understand why it's so difficult. And it's Eric Kandel again. And he says, in these cases where we have top-down synaptic modification, there is a slight stimulation that release the neurotransmitter. There is an increase of the neurotransmitters in the synapse, but the nucleus is not involved. And we are in the short time memory. And to go from a short time memory to a long time memory, you need repetition, repetition. And if you have patients, you see once or twice a week, you give them exercise. The parents do the exercise at home. You will have, okay, I have time? If you well do the repetition, that will have a message between the synapse and the nucleus that will change the nucleus. But if you go to a speech therapist once a week and do nothing, next week when you come back, half of what you have been learned is forgotten. So it's very important to, when you have top-down re-education, to do the exercise very, very, very seriously. But there is another way to stimulate the long-time memory, which is a biochemical way, and it's that an ideal emotional moment can bypass the normal constraints and produce enough MAP kinase to inactivate CREB2 and activate CREB1 to directly store the experience in your long-time memory. If you had a car crash 20 years ago, you always remember that it was Christmas night, you are with your wife, with the children, it was raining, and you don't need to repeat during 1 month all the circumstances, because all has been prepared. Thanks to this emotional fact, we have increased the production of MAP kinase. But there is some conditions which are necessary. And Joel's pose says, and have proved by the fact that the stress facilitated the mechanism of the memory only when it was fed at the moment when the organism has to memorize the event, and only when the hormones and the neurotransmitters activate the same network that are activated by learning. And is therefore, it's essential that there is a convergence in time and in space between learning and the cause of stress. Up. That's, oh. Up. Sorry. And really, I will just speak for a few minutes about Frogimov. But Frogimov is a new approach, and I found it by serendipity. Like all orthodontists, I put braces. And when I put braces, I want to see very well, and I don't want to have the lips very stiff. And various children were in re-education, and I put the braces, I put the appliance to show and not be disturbed by the lip contact. And during half an hour, the deglutition is correct. And I say, well, what happened? And maybe it's very important that the upper and the lower lip can't join, can't do the C-lip. And so if I can do the C, it's impossible to swallow by the old program. And so they must discover a new one, but it was the lower brain we discovered it. And so I try with a small I don't know what you call that, écarteur, and I saw its efficiency. And so I know it's rather uncomfortable, so I designed a new one, which more physiological, and it was the beginning of froggy mouth. And froggy mouth is a device which is worn only 15 minutes a day during a short time in front of a TV screen, because it's rewards which is recognized by the limbic system, and it will force the child to discover a new way of swallowing, but in an unconscious way, because they are looking to the TV and they don't take care what happened in the lower brain. And the child is so in phases of a contradiction, an impossibility, a question that forces him to reorganize his previous naive or incomplete knowledge. And the first child I put it was a child, EMC, he do wrong road, he come from the hospital, neurological service, and he can't swallow correctly. He's MCA, very difficult to do. And I say, okay, I put it. And in 2 weeks, you can see this side, which is impossible to have a reorganization, to have a top-down approach. You will put your tongue here, or so. Have discovered alone the good swallowing. Oh. So we try with lots of other children, and we can find that the froggy mouth is inhibiting the action of the facial nerves. And if we inhibit the facial nerves, you will active the trigeminal nerves, and the trigeminal nerves control the molar area, molar occlusion, so you close the mouth. If you close the mouth, the tongue go near the upper maxilla, and it will be very easy to swallow correctly by just a contraction of the styloglottis muscle. And we have changed all the organization. And this new program will immediately become part of the implicit memory. That is a memory that is not related to previous learning, which does not require repression, and whose recall requires no conscious attentions. We can say that implicit memory are stored in the cerebellum, in the striatum, and the amygdala. We have done some in Necker Hospital, and I say I'm sure that it was not the same area or are stimulated with a top-down approach, and we can see with the froggy mouth. This is on the beginning, a young girl, and we asked her to swallow, and there was stimulation of sensitive and deglutition area, and we put her the froggy mouth, and immediately you can see there is a great stimulation of other area of the motor area. So briefing, Tokisho Ono will have the real author of this, says the tongue is the respiratory organ. And the rehabilitation should not only concern the tongue, but all the orofacial practice. And it is impossible to treat swallowing and oral praxis without a restoration of nasal breathing. Both are completely linked. Bon, Guillaume vient me passer ces trucs-là. So, voilà. What is the tongue posture during nasal breathing? During nasal breathing, the tongue is upper. The mouth is full. And so it is impossible to have a buccal mouth breathing. So the breathing will be through the nose. When you have low tongue, there is room for the air to go through between the palate and the tongue, and you will have nasal breathing. And which is very important is that the tongue only is inside the mouth. And really, with breathing and with swallowing, my efficiency is to inhibit the bad program, not to stimulate the good one, but to inhibit for swallowing, I inhibit the seal. For breathing, I inhibit the possibility of mouth breathing. Slide suivante. And so when we see the link between nasal and swallowing, we have to speak about connexionism. And connexionism, there is models, mental or behavioral, which processes from the same or networks and which are interconnected with single units. And we can imagine that Sigmund Freud was the founding of the fathers of connexionism. And when you know psychoanalysis, you know what is hidden and how what is hidden can be only present in your life. S'il te plaît. All the functions are controlled by neuronal links. And the neuronal links we can see on the beginning was a communication between different synapses at the level. But it's like a phone call because it was an information from one neurons to the other ones. And you can change only by top-down approach, you can change one network. But, which is, s'il te plaît, la suivante, which is important, around the synapse, there are not neurons, but glial cells. And the glial cells are more important, more numerous than the shows. And they are around the synapse. They hear what says the synapse, and they say, oh, if it's important, I can give information to all the other wings, like for radio, and you say, oh, you know, for nasal, they change that. Maybe you can have also efficiency to, if you want to change something in your shows. La suivante. So we know that now the glial cells are the more important, and they control the timing, the location, and the plasticity of the synapse. And for the connexionism also, for nasal breathing, it's very important because we try to change the nasal breathing, but around the nose, there is also the olfactory links. And I generally, on the beginning, ask the child to smell two odors, to close the eyes, and to recognize. And so, as airway has no sensory, they take care because sometimes they have never understand that the air goes through the nose. And through the connexionism with the perfume, they can take attention of the good ways from respiratory. I want to show you some important cases that have been treated only with froggy mouth. And this child has always the tongue outside. And the parent was dentist, and I said, I don't think I could do something. And the child took froggy mouth, he put it, and the tongue enter. Suivante. And we can see that she has corrected. Suivante. This is treatment for narcoleptic cataplexic children, big open bite. she can't do any attention, no re-education possible. But she accepts the froggy mouth. Suivante. And without any treatment, we have corrected the open bite and the occlusion. Suivante. And which is very important, it's for class 3, because class 3 are very difficult to treat. And this guy has an hemilymphangioma. There is a very big tongue. And I just tried. The tongue is big, but just to change the posture. And when you see they have no treatment, we can see the class 3 because class 1, and without treatment, only with the froggy mouth and changing the posture, we have treated the class 3. And this is the last one. I just finished my presentation and my job because I just received some photos, and she was a Whitman-Beckwith. It is a very hard syndrome. And she is class 3 with glossectomy. She has glossectomy at 10 months. And when I saw her at 3 years, she was class 3. I just put 6 months upper appliance to stimulate the growth. And I says, oh, okay, no, there is an open bite. We are going to put only froggy mouth. And she lived. And she called me a few weeks later, and she says, oh, it's fantastic what you have done. She's completely correct. No, I would like to have a better occlusion. And this girl with a class 3, with a Whitman-Beckwith, only with a froggy mouth, has corrected his occlusion. So there was a lot of things to do it, but for the next time, for Geneva, we will speak about things. Thank you very much for your attention here.